Test 1, 2.
Gotta lay off the caffeine order.
Test 1, 2.
He's an employee, so
order. Welcome to the February 18th, 2021 meeting of the Access Health Connecticut Board of Directors. It is requested that participants introduce themselves each time they speak. Roll call votes will be taken for every action item. At this time, Marcin, when you call the roll for attendance.
Paul Philpott.
Here.
CC Woods. Thomas McNeil.
Here.
Brian Brader.
Here.
Victoria Veltri.
Good morning, I'm here.
Morning. Steven Hernandez.
Good morning.
Matthew Brackman.
Good morning.
Michael Gilbert.
Good morning.
Gregory Messner. Peter Doolittle. Yvonne Addo. Paul Lombardo.
Here.
And Heather Aaron.
Morning here.
Thank you.
Martin, I think CC Woods just joined.
I did.
Okay. Good morning, ma'am.
Hi
Good morning.
there.
Great. Okay, at this time, the vice chair would request that members of the senior leadership team who are present introduce themselves.
Good morning, all. James Michel, I'm the Chief Executive Officer for Access Health Connecticut.
Good morning, Tony Crow, Chief Operating Officer for Access Health Connecticut.
Good morning,
Andrea Roberts, Director of Marketing Access Health.
Good morning, Daryl Jones, Finance Director, Access Health.
Good morning, everyone. Rob Lundo, Director of Technical Operations and Analytics.
Good morning, everyone. Susan Richby, Director of Legal and Governmental Affairs, Access Health.
Morning, everyone. John Carbone, Director of Shop and Product Development.
Hi, everybody. Good morning. Glenn Jurgen, Director of Human Resources.
Good morning, folks. Dan Maloney, Director of Information Technology.
Mr. Chair, I think this concludes the introduction of the senior leadership team.
Thank you, James. At this point, the chair would entertain a motion to approve the minutes of the January 21st, 2021 meeting.
So move. This is CC.
And I'll second it. Okay.
Any discussion? If not, let's call the roll.
Paul Philpott.
Yes.
Gregory Messner. Mike Gilbert.
Abstain?
Brian Brader.
Yes.
Steven Hernandez.
Yes.
Peter Doolittle.
Aye.
CC Woods.
Aye.
Thomas McNeil.
Aye.
Victoria Veltri.
Aye.
And Mr. Matthew Brackman.
Aye.
Thank you.
So the ayes have it and the motion passes. At this point, I'd like to introduce James Michel, our CEO, to give us an update on Access Health Connecticut activities.
Sure. Thank you. Thank you, Paul. I have a brief report this morning. As I said last month, the biggest part of this morning's meeting will be a presentation of the results from the health disparities study that we've just concluded. Good morning. I'm James Michel, the CEO of Access Health Connecticut. I want to welcome everyone to our February board meeting. Please note that this is a public meeting and there's a separate number for the public to dial and listen in. First and foremost, I would like to thank you for your continued support through our 8th open enrollment. We have an important agenda today. As most of you are aware, Access Health Connecticut opened a special enrollment period for uninsured residents in Connecticut this past Monday, February 15th. Once again, opening up enrollment for healthcare coverage due to the public health crisis still very much at hand. Susan will provide an update on this topic in a few minutes, and then Rob Lundo will briefly talk about the open enrollment final report that was forwarded to the board recently. As we move beyond open enrollment, our team is continuing to actively look ahead to the next 6 months, reviewing our messaging, evaluating our community outreach efforts, and adjusting messages as needed to clearly communicate to Connecticut residents the critical importance of taking care of one's health, especially finding a doctor, scheduling preventative care visits, and establishing regular checkups and with a primary care physician. The importance of Connecticut residents taking care of their health and well-being leads me to an area of utmost importance that will be covered in depth during today's meeting: health disparities in Connecticut. It is part of and central to Access Health Connecticut's core mission to reduce health disparities in our state. Today, we will be giving a presentation of our Health Disparities Project, which will showcase critical findings based on current data, stakeholder feedback, and consumer surveys. It's important to note the Health Disparities Research Project began last year during the COVID-19 pandemic, so its findings are current and reflective of the present-day state of healthcare disparities in Connecticut across our communities. As the saying goes, it takes a village, and health disparities is where we hope to connect all the dots. With the ongoing support, feedback, and leadership of statewide community partnerships to help us address health disparities head-on. We know health disparities are a statewide issue that greatly affects low-income residents and, in general, low-income communities of color. And the resources to address such disproportionate health disparities calls for an all-hands-on-deck approach. Our partners, Kara Mitchell, Principal of Client Services at Mention Hope, and Dr. Fred McKinney, and Dr. Gerald Janes, Principal at BJM Solutions, will be presenting the findings from this project. We are proud to start a real dialogue about one of the hardest issues to face communities of color in our state. And we welcome your comments, your feedback, and your insight as we continue to engage in an open dialogue about health disparities that exist in the great state of Connecticut. We will close our meeting with a review of future agenda items, which include the 2022 standard plan designs and QHP certification for requirements for the next year. Discussions about establishing a subsidiary, as well as strategic initiatives that may come out of the health disparity study. Again, those are ongoing discussions we're having for future discussions with the board. Once again, I thank you for joining us today and being here with us today. Thank you to everyone who continued to support, contribute their time, energy, and knowledge to our organization. We appreciate your tireless efforts throughout the year. And on behalf of the entire team at Access Health Connecticut, we look forward to a healthy and productive year together. At this time, Mr. Chair, I will pause for any questions.
Any questions for James? So thank you, James. And I'd like to introduce Susan Rich-By, Director of Legal and Governmental Affairs, for an update on special enrollment.
Thank you, Paul. Susan Rich-By, Director of Legal and Governmental Affairs. This is an update on a new special enrollment period that Access Health just opened. I just realized there's a typo on the slide. It is 2021, not 2022. So last month on January 28th, President Biden issued an executive order for the U.S. Department of Health and Human Services to consider a new special enrollment period for the federally facilitated marketplace, also known as the FFM, due to the exceptional circumstances of the ongoing COVID-19 pandemic. CMS subsequently determined that the special enrollment period should be open for the 36 states served by the FFM due to the exceptional circumstances of the COVID-19 pandemic from February 15th, 2021 to May 15th, 2021. Next slide, please. So Access Health has also decided to open up a new special enrollment and follow the FFM, but with slightly different details. The initial period for Access Health started on February 15th, 2021, and it will run till March 15th, 2021. As we get close to that date, Access Health CT will assess whether additional time is needed for the public to come in and enroll people who may be uninsured and need assistance. The special enrollment period may continue up until April 15th, 2021. During this special enrollment period, uninsured consumers may enroll in a QHP during the special enrollment, and no verification of their eligibility for the special enrollment period will be required, as normally is required during the rest of the year when people enroll in special enrollment periods. Current QHP enrollees, however, are not eligible to change plans during the special enrollment. It is only for individuals who are not currently enrolled with Access Health CT. Financial assistance will be available as it always is. Consumers may enroll online or by phone, and enrollment assistance will be available in multiple channels. Thank you.
Thank you. Questions for Susan? Okay, thank you, Susan. And now I'll introduce Robert Blundo, Director of Technical Operations and Analytics, for an open enrollment 8 final report. Rob?
Thank you. Thank you. Good morning, everyone. So a very, very brief update today. In our last board meeting, I had reviewed the results of our 2021 open enrollment. At the end of that meeting, I had promised that we would be delivering a full comprehensive report of the open enrollment period. As promised, so we've emailed that report. It's the 2021 open enrollment summary report. That's been emailed to the board as well as posted to our public website. At the very top of the slide here, you'll see the URL and the navigation directions to get to that report. As a brief reminder for all, so this report includes over 50 pages worth of charts and tables, which really cover the customers we serve, the customers and how they churn across products, the products they purchased, as well as the cost of those products. This year, we've added 4 new exhibits. 3 of those exhibits are focused on premium and out-of-pocket costs and their trends over the past 5 years, as well as there's a new table that's been added, which further drills down into customer churn and breaks it out by race and ethnicity. Before I close out, I'd like to remind everyone that as they review this report, again, Access Health is always here to answer any kind of questions that may come out of that, as well as if there are any requests for future additions, we're always here to accept those and work on that for the future improvements. With that, I'll pause, and as I promised, this is a very brief update. Thank you.
Any quick questions for Rob? Okay, James, I want to give you and Rob a heads up. I'm going to be haranguing you later with a bunch of email questions related to open enrollment. So by way of heads up, but I want to move this forward to the health disparities discussion. Okay, so at this point, there being no other questions about open enrollment, James, why don't you take it from here?
Sure. Thank you much, Paul. And Paul, we look forward to your questions about anything at all, and we'll do our best to answer them as quickly as possible. Thank you, Paul. This health disparity study has a great deal of data that makes it clear that health disparities in Connecticut continues to grow, and that means those who live in the communities of color continues to suffer needlessly and die at a much younger age compared to the rest of Connecticut. In this presentation, we will humanize all of this data by connecting real people to the data from our study. We have a video of Connecticut residents talking about their experience with the healthcare system. We will also show you a website we are developing that will host real-time health disparities data for public usage. This study outlines the key drivers of health disparities in Connecticut. We're very fortunate to have 2 Connecticut small businesses to help Access of Connecticut conduct this study. BJM Solutions is a small business in New Haven that specializes in data analytics, specifically health-related data, and Minton Hoke, a marketing firm from Avon who has extensive experience in doing marketing and outreach efforts across the state of Connecticut. I would like to extend my thanks and appreciation to Darrell Jones, our Director of Finance, and John Carbone, Director of SHOP, for leading this project for Access of Connecticut. Also, I respectfully ask that the board members, if you could hold on to your questions until after the presentation, as it is a lot of data, and we want to get through it. And at the end of the presentation, we would answer all of your questions. Thank you very much. So at this point, I want to turn it over to BJM Solutions and Minton Hoke.
Thank you so much, James. Kara Mitchell, Principal of Client Service with Minson Hoke. Good morning, everybody. In May of 2020, Access Health Connecticut contracted with BJM Solutions and Minson Hoke to assess the state of health disparities in Connecticut and to provide recommendations for how Access Health might be able to address health disparities moving forward. Next slide. Again, my name is Kara Mitchell. I'm a principal with Minson Hoke, overseeing client service. Minson Hoke is a Connecticut-based advertising agency. For 50 years, we have been solving for consumer unmet needs in the state and globally. We work with many leading Fortune 500 and 1,000 organizations, and also with many state-based organizations to take on all manner of complex and sensitive issues related to social issues in our state. I'm going to turn it over to Dr. McKinney to introduce BJM Solutions.
Thank you, Kara. Good morning to everyone. My name is Kara said, is Fred McKinney, and I'm a principal at BJM Solutions. BJM Solutions is a Connecticut-based economic consulting firm, specializes in public policy analysis. Our principals are Dr. Gerald James, who is with us today, and myself. We have combined over 70 years of experience working for organizations as wide-ranging as the White House, Rand Corporation, Yale University, and dozens of corporations, states, nonprofits, municipalities, and cities around the country. BJM Solutions is a certified minority-owned enterprise. Kara?
Next slide, please. One of the main takeaways from the research, which those of you that have had a chance to read would have seen, is that despite Connecticut's high ranking in income and health, many indices that we reviewed as part of this study reveal disturbingly large disparities in the health status and healthcare delivered to lower income residents in general, but more specifically even to lower income people of color. We're going to walk you through an example of two hypothetical young boys born on the same day. And based on the indices that we have reviewed and the data that we've gleaned from this study, show you how their quality of life and ultimately their life expectancy differs as a result. I'll turn it over to Dr. McKinney and Dr. James. Next slide, please.
Good morning. This is Gerald James of BJM Solutions. Our intention with this vignette on the screen is to illustrate how throughout the life cycle, disadvantages at birth accumulate almost exponentially toward a destiny of health disadvantage for infants born in our state's most disadvantaged neighborhoods. For example, based on actual data, suppose Marcus and Tyler are each born in Connecticut, one in Northeast Hartford and the other merely 5 miles away in West Hartford. Next slide, please. In Marcus's neighborhood, the population demographics are 60% Black, 5% white, and 34% Hispanic. In Tyler's neighborhood, it is 91% white, 5% Hispanic, and less than 1% Black. Although they are each born on the same day, hypothetically for us here, December 31, 2020, their life experiences are dramatically different.
At birth, we see those differences in healthcare developing very early. In Marcus's neighborhood, the infant mortality rate is more than 3 times the infant mortality rate in Tyler's neighborhood 5 miles away.
Despite facing this higher infant mortality rate, Marcus reaches his first birthday. Unfortunately, both boys develop asthma, but Marcus's asthma goes untreated, and his school attendance becomes a challenge.
We know from the data that in Marcus's neighborhood, the absenteeism rate for children in schools is 24% compared to less than 6% absenteeism in Tyler's neighborhood. We also know that in Marcus's neighborhood, the community has a 13 times higher uninsurance rate than the uninsurance rate in Tyler's neighborhood. Also in Marcus's neighborhood, the rate of obesity is 36% compared to the rate of obesity in Tyler's neighborhood of 26%. Next slide.
Both of the boys try out for football, but with his untreated asthma, Marcus is cut from the team. This, plus his access to few healthy food options, contribute to his increasing weight.
In Marcus's neighborhood, the food insecurity rate is more than 2.5 times higher than the food insecurity rate in Tyler's neighborhood.
Despite his attendance difficulties, Marcus works hard to graduate from high school on time, as does Tyler.
In Marcus's neighborhood, 77% of the children graduate from high school with a high school diploma. That's compared to over 97% of high school diploma rates in Tyler's neighborhood.
Both boys dream of college, but Marcus can't afford it. And due to health-related absenteeism, his grade point average is too low for him to receive scholarships.
In Marcus's neighborhood, only 7.5% of the children earn baccalaureate degrees, compared to over 80% of the children in Tyler's neighborhood. Next slide.
Without a college degree, Marcus's opportunities are limited. His low-paying job has no benefits and just covers rent and inexpensive, mostly processed foods.
In Marcus's neighborhood, the median earnings is $37,000 compared to median earnings in Tyler's neighborhood of $96,000. In Marcus's neighborhood, we know that 11.6% of adults are diagnosed with diabetes compared to less than 9% in Tyler's neighborhood. And we also know by this time in their lives that in Marcus's neighborhood, the uninsurance rate is now almost 30 times the uninsurance rate in Tyler's neighborhood.
Both Tyler and Marcus reach age 50, but Marcus spends his birthday in the emergency room. There he learns he'll need medications, which he can't really afford. Marcus continues to struggle, and he dies at age 68 as a result of diabetes. Given his life expectancy rates, Tyler goes on to live well into his 80s. Next slide, please. Next slide, please.
Because of lower life expectancy, Marcus also loses out on income that would have come to him had he lived as long as Tyler. We estimate that that amount of money is about $400,000 in lost income to Marcus and his family because of his early demise. And I'm going to go off script for 1 second to mention that the CDC just came out with a report this morning that said that the life expectancy in the United States as a whole declined by 1 year because of the pandemic, but it declined for 2 years for Hispanic and for 3 years for Black Americans. Next slide, please. Kara?
Thank you, Dr. McKinney. So today we are going to go through a high-level overview of the study methodology that we completed, or the work that was completed. We'll talk through the study findings, so the results from each part of the study. We will go through the implications and recommended actions that we see. We will also talk through a data website demonstration, so a public available data site that will be created, and then some next steps. Next slide, please. The project was ultimately launched, this data grounded study, in June of 2020 and was completed in 3 parts. The first part of the study was a review of third-party data to identify and quantify health and health-related issues, morbidity and mortality causes, and their relationship to demographic and socioeconomic status factors that drive health outcomes. After reviewing that secondary and third-party research, we were able to pivot to an additional viewpoint of stakeholder perspectives. And so in the second part of this study, we did solicit those perspectives from many Connecticut stakeholders to understand their perceptions of Connecticut's health needs, but also their perceptions of Access Health Connecticut, so that we could understand more about the potential for partnership opportunities around product, service, and support ideas moving forward. And then thirdly, an additional viewpoint was to understand consumer perspectives. We distributed a consumer survey that was designed to understand Connecticut residents' views on health and health-related topics, along with their interests and desires to engage with health-related products, services, and supports. Next slide, please. So we will break down some of the study findings in each of those parts. Next slide, starting with part 1, and I will turn it over to Dr. Janes to walk through those findings.
Dr. James back. As Kara said a few minutes ago, a central theme of the research findings is that the comparatively good health of Connecticut's population, when measured against other states, hides significant pockets of gross disparity. These disparities and underlying health inequities are many and deeply disturbing. The stark and revealing differences in health outcomes are most manifest in terms of geography, income, and race and ethnicity. A few slides will be presented to illustrate this central finding and its relationship to the previously mentioned social determinants of health. So on the slide before us, we see that African Americans suffer from the largest disparity in 6 of the top 10 causes of mortality in Connecticut. The bottom of this slide lists the top 6 diseases with the largest health disparities in the state. The number to its left represents a disease's ranking in terms of health disparity. The number on the right is its ranking in terms of overall mortality rates. While it is important to confirm that focusing on diseases with large health disparities on the left, also the number on the left, also focuses on top 10 killers, the numbers on the right, such as heart disease, cancer, stroke, and diabetes, rather than spending time discussing specific diseases, we focus on general conditions and factors that tend to drive disparities in all diseases. Next slide, please. This slide lists the top 5 and lowest 5 neighborhoods as defined by a census tract, which is about 2,000 people in the state of Connecticut, ranked according to life expectancy in these tracts. As shown in the table, the demographic and socioeconomic characteristics of these cities provide a more general illustration of the graphic comparison of life prospects for the 2 hypothetical infants, Tyler and Marcus. Tellingly, poverty and its relationship to numerous other social determinants of health dictate life expectancy, the most salient index of a community's overall health status. Unsurprisingly, the neighborhoods with the lowest life expectancies in this table are also overrepresented among Connecticut areas with limited access to fresh foods and medical services. Next slide, please. The red-colored areas of the map designate census tracts that are both food and medical deserts. These desert tracts overlap with the low life expectancy tracts. Several cities, including Danbury, Norwich, Waterbury, Wyndham, have 4 or more census tracts within them that are both food and medical deserts. Next slide, please. This slide shows COVID-19 case and death rates by group. And it illustrates a specific set of outcomes that are due to the social determinants of health. Considering any of the groups represented on the graph, let's say whites on the far right, the reddish first bar shows their percentage of Connecticut's population. The blue bar, their percentage of positive COVID-19 cases, and the orange bar, their percentage of COVID-19 deaths. Whites are underrepresented with respect to COVID cases, a consequence of their higher socioeconomic status, less dense, higher quality housing, proximity to supermarkets, allowing them to stock supplies, their higher likelihood of being able to work from home or not need to use public transportation to travel to work if they need to do so, all allowing greater opportunities to practice social distancing. Alternatively, whites' higher aged population leads to a disproportionate death rate from COVID, despite a lower likelihood of contracting the disease. For the opposite socioeconomic status reasons, Blacks and Hispanic Americans are overrepresented with respect to likelihood of contracting the disease. Blacks are also overrepresented in death rates, and the Hispanic population is underrepresented in the death rate, likely due to its very youthful age structure in comparison to the rest of the Connecticut population. Connecticut's Asian American population is underrepresented in terms of both case rate and death rate. Next slide, please. HCT's core mission is to expand health insurance coverage. This slide illustrates the importance of health insurance to overall health status as represented by that index, life expectancy. The dense cluster of dots to the left of the figure show that most Connecticut census tract areas have low uninsured rates between 0 and 5%, with life expectancies generally exceeding 75 years in these areas. The figure also shows a multitude of census tracts with uninsured residents exceeding 20%, and in some cases over 30%. The high uninsured neighborhoods to the far right represent disproportionate populations of lower income working people. The low life expectancy, moderately high uninsured tracts in the center represent high poverty Medicaid populations. Further evidence of this is shown later during the presentation. Next slide is for Kara.
Thank you, Dr. James. And so data tells a really compelling story for us, but to be able to round out that story, we do need the contextual approach. We need some feedback from our different audiences within the state to learn a little bit more about what is driving some of those results. Next slide, please. In part 2 of our study, we did connect with stakeholders throughout the state of Connecticut. We conducted 45 in-depth interviews with leaders of key stakeholder organizations, and those organizations included public, private, and nonprofit sector entities currently supporting health and health-related causes in the state. In addition, we conducted an online survey of CACs, brokers, community partners, and navigators following after the interviews to understand more from their perspectives. Next slide, please. While the research report details a lot of information that we've received from stakeholders, today we're going to talk about the 4 broad themes that we heard from stakeholders. And the first theme is that this work will require the development of partnerships and cooperative efforts utilizing the resources and skills of the state's many healthcare stakeholders. Stakeholders want Access Health to clarify its role, given the organizational characteristics and mission currently at hand. The stakeholders believed that the resolution of problems should be based on a deep understanding of communities and therefore should be driven by the communities. And so how Access Health works to address health disparities is going to be very important in terms of its partnership ability and cooperative efforts moving forward. The second stakeholder theme was around expanding access to healthcare and reducing health costs require expanding health insurance to lower income minority communities. We just saw that as the data represented from Dr. Janes, and the stakeholders obviously are in agreement that access is critically important. This is core to Access Health's mission today, and Access Health is doing a ton of work in this area, and stakeholders recognize that. The reality is that they want to see us continue to focus in these areas. And in addition, they did talk a lot about focusing on those populations that fall just outside of the Medicaid threshold. And so really honing in on those audiences that may need some additional support as it relates to health insurance and healthcare support. The third broad stakeholder theme that we heard was around establishing racial and ethnic equity in health outcomes and reducing the cost of services, and that this will require greater participation and leadership roles for minorities in local communities. The stakeholders believe that we need to work with community leaders to address root barriers of health inequity. And in some cases, they recognize that some communities do not have many people in these leadership roles and would love to see Access Health mentor and support the development of leaders in these communities. How can our research and our experiences help to grow leaders in these communities? And the fourth stakeholder theme that we heard was that there are large gaps of information about health and healthcare options in minority communities, and this needs to be addressed with better dissemination of educational information to improve the understanding of healthcare options and life care choices. This, again, is work that's core to Access Health's mission today, and we're doing a lot of work in this area. I know the organization is today to disseminate this type of information. However, stakeholders are still concerned with the lack of accurate information and does want to see Access Health do more to provide more accurate insurance and health navigation support for people. So not just education in terms of tangible educational materials, but actual support and hands-on support around navigation of health and healthcare. Next slide, please. And so to round out additional contextual feedback, in part 3, next slide, we did conduct surveys with consumers in the state. We reached out to 1,006 Connecticut residents in an online survey between November 23rd of 2020 and December 21st of 2020. The overall goal of this survey was to assess barriers consumers say they face in accessing health insurance and health care, and to gauge their interest in various products and services. It's important to note that in research, oftentimes some of the findings may be slightly different than what we've seen or heard in data, or will provide additional context to what we see in some of the data. Consumer perceptions are their realities, and as James had mentioned at the top of this, really understanding the human component to this is important. And so as we talk through some of the findings from consumer perspectives, it is important again to know that their perceptions are their realities and they do contribute to disparities. Next slide, please. In terms of the barriers to accessing healthcare, they can be very pervasive, and residents who are experiencing barriers often experience multiple challenges rather than a single isolated problem. So what we've seen from the study is that the following groups are more likely to experience barriers to getting healthcare: those with a low socioeconomic status, residents insured through Medicaid or Husky or non-traditional plans like catastrophic plans, residents who say they are in poorer health, so they believe or they do have additional medical diagnoses, residents of color, female residents, and residents having other social determinant of health risk factors. And while these characteristics are demonstrated from the research, our research did show that we must consider other root causes of health disparities beyond just these characteristics alone. Next slide, please. Our research found that consumer experiences within the healthcare delivery system oftentimes exacerbate the income of other social determinants of health and cause underutilization of the healthcare delivery system. Particularly, there were 3 key areas of experience that provide barriers to the healthcare delivery system. The first not all insurance plans are accepted or treated equally. The second, for consumers, the cost of healthcare is unmanageable. And the third, poor patient-provider relations exist. So let's dive into each of these three a little bit more. Next slide, please. In the first, as we look at consumer experiences in the healthcare system, differences in insurance plans mean unequal opportunities for consumers to access healthcare. So simply having insurance does not guarantee equitable access or treatment. Residents reported experiencing delays in getting care and receiving poor quality service due to having a certain type of plan, and they feel discriminated against when these challenges occur. Residents begin to distrust and resent the system when they feel that their insurance plan dictates care more than doctors' assessments of patients' best interests. On the other hand, residents insured through an employer-sponsored health insurance plan or Medicare were less likely to report these types of issues. And so the system is creating inequity based on insurance status and plan type in terms of consumer perceptions. Next slide, please. The second experience is the cost of healthcare is unmanageable, and it discourages vulnerable groups from engaging with the healthcare system. Cost is beyond just premium, as we know. This goes to copays, this goes to deductibles, and members of vulnerable groups from our study are disproportionately likely to say that cost of care or insurance coverage is a top barrier to healthcare engagement. Cost concerns result in a chronic dread and avoidance around getting care because many consumers feel they cannot afford it even with coverage. Some people even feel exploited by healthcare providers due to perceived financial conflicts of interest or experiences with care that were poor in quality yet high in cost. Next slide, please. And the third key barrier in terms of the key experiences that we saw from consumers is that poor patient-provider interactions, often rooted in providers' implicit bias, drive unequal health outcomes in multiple ways. System and stakeholders often point to cultural issues at the basis of distrust in healthcare institutions, especially for people of color. But our respondents did point to poor patient-provider interactions driving more of their distrust and anxiety. Consumers feel discriminated against based on their gender or gender identity, their race or their color of their skin, their medical history, especially those with substance abuse or mental health complexities, their medical condition, their insurance status and type, as we just mentioned, socioeconomic status, and if they have a language that's different or an accent that's different than their provider. Our research is suggesting that these poor patient-provider interactions uniquely drive distrust in the healthcare system, and that we can no longer point to social issues alone. We must consider the patient-provider interactions moving forward. Next slide, please. In addition, in our study, we had talked to consumers to understand more about how they value their health. And across the board from our research, we did see that consumers overwhelmingly do value their health, and most see the importance, even within low socioeconomic statuses, of having health insurance. And when we asked them to evaluate their interest in insurance and other health-related products and services, there were a few areas in particular that consumers were gravitating towards. Products and services with direct concrete benefits, so additional support for dental, additional information around things that have a tangible benefit for consumers. Solutions that increase opportunities to get timely care, so in-community care support, navigational support, transportation support, how they can get access to that care. Engagement-related solutions, concierge type services to assist and connect. And also a final note that we did hear from consumers as it relates to health-related products and services, we need to consider audience-specific communication when discussing insurance benefits, whether that be rewards, etc. Each audience has different needs, and we have to be cognizant of those needs and make sure that we're communicating on a one-to-one level. Next slide, please. We're going to talk a little bit about the implications based on these findings and the recommended actions. Next slide, I'll turn it over to Dr. McKinney.
Thank you, Kara. To achieve its mission to improve the health of the people of Connecticut by reducing the population without health insurance and increasing access to and utilization of health and medical services, Access Health CT can help to address the substantial health disparities between the state's racial and ethnic, rural and urban, and different income groups. Kara?
Yep. Next slide. Please. Yep. And so based on our findings from all three parts, our recommended area of focus for the organization is to focus on system-level changes of healthcare access, healthcare usage, and healthcare insurance. Access Health Connecticut will be better positioned to solve for its core mission of the reduction of the uninsured and to address health disparities by staying focused in these three areas to support the state and reduce the suffering. Next slide, please. So within those three areas, there are 5 areas specifically that we see as being important for Access Health. The first is to address systemic causes of health inequity. Healthcare cannot be an observer of issues or continues to suggest that health inequity is sustained by broader social forces alone. Our research did show that vulnerable groups feel that the healthcare system shuts them out and hinders their engagement in various ways. It is clear that consumer experiences within the healthcare delivery system exacerbate the impact of other social determinants of health and play a powerful role in perpetuating unequal health outcomes. Implementing solutions at the system level will be critical for meaningful advances in health equity and reducing root causes of consumer healthcare avoidance. Next slide. The second area of focus is to improve patient-provider interactions. We must address implicit bias in healthcare and recognize how providers may be unwittingly contributing to inequities. And we will help focus with stakeholders and other partners on strategies that aim to reduce the impact of bias. And those might include efforts to make care more patient-centered, bias training, fostering organizational climates that are truly committed to equity, encouraging diversity in physicians and organizational leaders. Next slide, please. The third area of focus is we need to take proactive measures to get people to engage with care. So we know from our research that people benefit from both intrinsic and extrinsic rewards to take interest in their health and well-being and to get and stay on any form of a care path. However, they also need someone to reach out and bring them into the system first before they can get on this path. And so how can Access Health play a role in helping people re-engage them into the system and to help get people to engage with their care? Next slide, please. The fourth area of focus is to assess current work around data and information centralization to see how Access Health can help. There are many organizations that are supporting underserved communities that have a limitation to how data is shared or are unable to access data sharing capabilities. Access Health has a lot of data that we've just gleaned from this study. How can we share some of that information and data, and how can we better support the state in its efforts to centralize data? And the last area of focus, we did hear from consumers. Next slide, please. Next slide, please. We did hear from consumers that Access Health Connecticut's brand perception is neutral to positive, and that provides a huge opportunity for Access Health as we are partnering with other organizations and we're trying to reintroduce people into a system that they do have anxiety around or do have some distrust with. This opportunity for Access Health, given that our brand perception is neutral to positive, we could play a role in helping to reintroduce people into the system. Next slide, please. And while the research identified other areas of importance and other social determinants of health like economic stability, food and diet, physical, environmental challenges, education, community and social, all of these areas are equally as important, but not currently within the purview of Access Health Connecticut today. And so our focus on system level changes are more important, but yet we can still collaborate with other entities to provide relief for those residents suffering within these areas. Next slide, please. I'm going to turn it over to Dr. McKinney to talk about a data website in development.
Thank you, Carol. So our data website, or our hub, it's also called, is a dashboard. And the purpose of this is to document real-time health disparities data. We will also, with this tool, assist stakeholders reduce health disparities. The data works to help us tell a story about health disparities in the state of Connecticut. The hub, the website, the data also will allow for improved collaboration among stakeholders to work with Access Health to reduce health disparities in the state. Next slide, please. So we're going to go through a demonstration of the hub, the dashboard. Next slide, please. Next slide. Okay, thank you. So this is the home page of the hub, the dashboard. And in this dashboard, what you'll see is that a user, and the users might be an elected official, it might be a hospital administrator, it might be an insurance company executive, it might be a community leader, but they could access this hub for different types of information about what's taking place in Connecticut. And so here are three different buckets of data that the user could access. There's data on health disparities, we have data on uninsurance rates, there's data on life expectancy, and we'll talk about some future types of data that will also be a part of this dashboard hub. We're going to give an example looking at uninsurance rates to give you a sense of how you could use this tool. So here is some data in the dashboard on Connecticut uninsurance rates by town. And so to the left, you see towns ranked from the towns with the highest uninsurance rates to the towns with the lowest uninsurance rates. The black bar, vertical bar there, indicates the uninsurance rate for the state as a whole. And so anyone, if you were interested in your town or another town, you could click on any of those bars. But before we do that, I want to introduce the map to the right. And so the map to the right is, of course, Connecticut, and the map it is a map that is also live. So you could hover over a community on the map, and it would also share information, in this case, about the uninsurance rate in that particular area. And so if you pick a town, let's pick a town, say Norwalk is fine, it's at the top. And so Norwalk now is highlighted on the map, and below the map, you see some data on Norwalk, specifically that the uninsurance rate in Norwalk is 17.6%, and the Medicaid rate in Norwalk is 13.6%. And so this allows, again, for if you're an elected official in Norwalk, or if you are trying to improve conditions in Norwalk on health disparities, this could provide some helpful information on the uninsurance rate. So we can go to the next slide, please. Next slide. So this dashboard, as you can see, can be a very powerful information tool for policymakers, decision makers, and those interested in reducing health disparities in the state. And this came directly out of the research of this study. So we see this as a tool that is really never going to be finished, I run the risk of saying that, because the data is always updated. But we are ready to launch this tool in the summer of 2021. We will have a next phase, phase 2, we will be doing advanced interactive dashboards, success stories, and best practices. And in phase 3, it'll be fully interactive for decision makers and individual consumers. And so you could imagine, if you are a consumer in Connecticut, you might want to find out where the healthiest town in Connecticut is. We see this as a tool that could affect a lot of things in addition to health disparities, and a real asset of Access Health CT. Next slide, please. Next slide.
the Black community don't have the privilege a lot of times of staying quarantined. The brown people, they don't.
I've heard a story from my mother, even from the day I was born, where she complained about pain for quite some time, and it took my grandfather to raise hell in the hospital for them to check on her. And they realized that when I was born, they left a tool and gauze inside of her. And my mother always felt like if she had been a white woman, it wouldn't have taken all this battle in order for them to just see why she had such a high fever, why she had so much pain after giving birth.
There have been years and years of policy making that have disenfranchised a large portion of the population. And I think that's the result we're seeing now. Things like redlining, things like medical experiments on Black people, things like what I call implicit bias, where you assume because somebody is different than you are that they are less worthy. So all these things, I think, have contributed to the system that we see now.
They need to make sure that there's like an ethical test, because if you can't even work with me because I'm a minority, how are you going to treat a patient of minority that's coming in here?
I hope that they use that education to not see the color of my skin, but see my physical condition. And I hope they're treating my condition, not my ethnicity. That's what I'm hoping.
There is a reason for Black and brown people not to trust the system. So it is incumbent of the people who practice now in the system to make it more trustworthy.
Thank you. With that video, we wanted to personalize, to humanize the data that we have collected and presented in this study. So I'd like to hear your feedback after we're done. I'm going to turn it over to Kara now.
Thank you, Dr. McKinney. And as the video had stated, together we can address these issues of health disparities. So our assessment has completed in terms of the research. We've shared those findings today at a top line. Now we are moving into an ideation phase where we are brainstorming with Access Health leaders around the 5 key areas of focus to understand more how the organization can work together with other organizations to provide relief for those Connecticut residents who are suffering. We will be coming back to the board of directors with a recommendation once ideation is complete on next steps and how Access Health looks to move forward. Next slide, please. We will pause.
Thank you much, Kara and Dr. McKinney and Dr. James for presenting the results of this noteworthy study that humanize the data that that tells a story about the issues of disparities in the state of Connecticut as it relates to health. But as we know, again, based on my review of the study, the 3 biggest drivers for me, and what takeaway for me is economics. It's a big driver, probably maybe the biggest driver of health disparities. Just because people are poor, and what drives them to be poor, and that's a different issue, but because of their economic status. And second is the healthcare system itself, how they're treated. And thirdly is the implicit biasness within the healthcare system. So I wanted to kind of summarize that, and obviously this is very personal for Access Health. It's part of our mission, and we are, as Kara indicated, right now we are going through a brainstorming session within the organization, using all this data on the result of the work of BJM and Menton Hoke to determine exactly what our next steps are with respect to our mission and vision, and go back to the board and working through the strategic subcommittee of the board, then ultimately to the board to present our thoughts and ideas of the next steps for Access Health as it seeks to make a contribution towards reducing the suffering of health disparities. So with that, Mr. Chair, I would turn the meeting back over to you for any questions anyone may have for us.
Thank you, James. I'm going to make one observation very quickly, and I'm going to turn it over to my colleagues for questions. Kara, Dr. McKinney, Dr. James, thank you for what I think is an incredible job on this report. I mean, it's just spectacular. I think this is one of those things where when you look at it and after you have kind of looked at the report, it makes, I mean, the health disparities issue is so big, all-encompassing, that I think the problem is it induces paralysis. And that's why I'm very interested in the concept of the information hub, because that provides at least the first step for some action to remedy the situation, or at least contribute to a remedy of the situation. So my one question, James, is, are we prepared to fund that? Are the resources in place to move forward with this immediately?
Paul, this was part of the research. The database has been developed. We have the ongoing maintenance, updating on that. We don't think it's going to be a big cost for us. Yeah. But we think this is worthy of doing, because I think that Fred, maybe you can talk a little bit more about other types of data that ultimately we will have after phase 2 and phase 3. But Paul, we think based on our assessment, this is the first of its type in the country where we will have a central location that's tracking health disparities across multiple indices, not just uninsured, but also the disparities in life expectancy, disparities, and maybe Fred could talk a little bit more about it. Food deserts and medical deserts. Go ahead, Fred. Yeah. By town, by census.
Yeah, I mean this is a very powerful tool, Paul, and I can imagine. There's been some recent studies about the whole issue of COVID vaccination rates and the disparities that are associated with COVID vaccination, that this tool could really highlight and focus attention on where these problems exist and would help the state or the medical community address these issues. We know, for instance, that the Black community is being vaccinated at about 3%. Which is significantly below their percentage of the population. And so some of this is demand, but some of this is supply. But this tool would allow us to identify those pockets. We're not there yet. That's like a phase 2. We also, as James mentioned, we have the ability with this tool, once it's established and it's just about done, we can address current issues that come up that we don't even know about right now. So, we could be tracking flu in communities. We could be tracking absenteeism in communities that are associated with some health causes that would, again, allow educators, for instance, to use this tool to say, we've got a problem that's different from problems in other communities. We have to address it. So I agree with you. This is a very powerful tool and one that is going to be a real asset for the state and for Access Health CT.
Thanks, Fred. I mean, I'm going to add one more thing, and then I'm going to call for questions, and that is, I think you guys know that these things are valuable only to the extent that you keep them current.
Right.
If you don't keep them current, it ends up being an outdated brochure online. Right. So I hope that when we think about this not as an event, but an ongoing process that we have some commitment to.
Yeah. So Paul, that's the ideation that we're going through right now.
Right.
And before we do anything, we'll come back to the board with our recommendations that's well thought out, and with the timeline to implement them. And obviously, if there's any additional cost, that'll be part of the presentation. Then we got to decide whether or not we have the resources to do it, and if not us, then maybe somebody else should do it.
Thanks, James. With that, I'm opening it to questions from my colleagues. Questions or comments, please?
This is Steve Hernandez. Firstly, I really, there's a paradox here in that this is, on the one hand, stunning. It's stunning, but it's not. I think we all expected this. We expected to see it, and it's still stunning to see it in front of us in this way. So I really want to thank you, first of all, for your efforts in creating not only this point-in-time analysis, but also, as the chair suggested, a methodology to continue to measure and address. What's really compelling about this work is that the outcome of health disparity is so closely connected, as you said, James, to all of the other social determinants that we see in our society. This is a mirror to the face of the state of Connecticut, and it's a pretty it's an embarrassing mirror to my mind, because what the data shows is that this is either by design or dereliction. So I'm really excited that Access Health Connecticut is taking on this part of its strategic vision so forcefully and so committedly through the creation of this tool. And again, I want to thank each and every one of you for this work.
Mr. Chairman, this is Ted.
Go ahead, Ted.
Thank you. Thanks so much for the work. I certainly want to align myself with Steve's comments. The health disparities is one of the reasons that animates my whole career. So I've been, pleased to see Access Health take this direction and encouraging it as much as I can behind the scenes. And I want to continue to do that, and whatever ideas we can come up with, will be worthy of consideration and possible support. Let me just say that building off the comments about the top of mind vaccine disparities, I recently had an op-ed in the Connecticut Mirror pointing out some of these disparate data and recommending to the governor that they simply, during this age-based phase of the vaccinations, 75 plus, and now we're down to 65 plus, that they go in and chop 10 years off that for the lower 1/3 of zip codes by income. And I just say that as an example for my final concluding thought, which is that you've got, the disparities are so deep here that if you come up with a neutral, seemingly neutral rule, like everybody over 75 gets vaccinated, you're doing it from the goodness of your heart. And I support the Lamont administration has done a good job in the rollout. But it turns out that a straight age base is actually discriminatory. It's because of these inequities that are baked in and that you illustrated in the vignettes. So to the extent that I see folks talking about getting for instance, vaccination rates up to even, that's not good enough. The vaccination rates for low-income neighborhoods should be at twice the rates in order to be equal. The vignettes pointed out that 65 is the same as 75 or more in West Hartford. I think when we're looking at the age-based cutoffs, we're actually measuring from the wrong end of life, right? Don't measure from birth, measure from the expected life expectancy of the person, because that is going to be much more of a proxy for their vulnerability and so forth. Anyway, that's my thought, which is that as we spin this out, let's remember that getting up to equal is not going to be enough. The more vulnerable communities will need to be above equal in terms of access to resources to bring them into what is really, truly an equitable situation. But appreciate the work, and comment was a little longer than I thought, but thank you for the time, Mr. Philpott.
Thanks, appreciate it, Ted. Any other observations or questions?
Yes, Mr. Chair, it's Vicky. First of all, James, thank you, and thank you to Vincent Hoke and participants in the presentation. It's a very powerful presentation of something that unfortunately we all know too well. Has existed for a long time, and even pre-COVID, we know that. We know that COVID has obviously highlighted, and I use the word highlight in a sort of ironic fashion, the issues that we have seen over time. I think my perspective on this is, I like the way this was put together because it encapsulates what we've seen. And it's a call to action. I think there are a lot of people, as you referenced, James, that are working on these issues across the state, including many of our agencies, and would really want to encourage Access Health to talk to our agencies and others in more depth before like coming back to the board for a strategy, only because we don't want to run parallel paths. We want to use our collective, I think, wisdom and resources in the best way possible. So I only say that because I think that's more powerful message. As you said at the beginning, it takes a village to address these issues with disparities. And so it's going to take a lot of us to work together. I just want to highlight a couple things. I think the importance of addressing the underlying issues and the upstream issues that create unequal health outcomes and unequal health access are absolutely critical. And we would invite everybody on this call who's listening to work and get involved with one of the strategies we have going called Health Enhancement Communities, which is investment in local community collaboratives who they themselves work on these upstream interventions like food security, nutrition, adverse childhood events, the contributors to these unequal health outcomes. The other thing I would say is when it comes to outcomes, you can only get better in outcomes if you really start measuring those outcomes and you measure what you're seeing. So just to put a little plug in that OHS has a bill in 6454, which requires the collection of race, ethnicity, and language data through the Health Information Exchange, which we think is critical to improving access to care, health outcomes, and improving policy making and interventions in areas where there are gaps in coverage, gaps in access, gaps in outcomes. And the last thing I'll say is you're absolutely right about measuring how we do. And we are, in our work, baking in and stratifying data on race, ethnicity, and language, and also stratifying measures of outcomes and developing quality measures that are based on health equity. All of those things together won't only solve the problem either. So my only point is we have to bring these pieces together to all work together. And I know you know that because we've talked about that in the best way possible, to use our resources in the wisest way possible for us all to get the biggest, return on this serious level of investment we need to make. So thank you again for the presentation. Very powerful. Thank you.
Thank you, Vicki. I see Mike Gilbert has a question. And let me just make this one comment. Unfortunately, I can't see everybody on my screen. So if I don't call on you, just at the next opportunity, just go ahead and jump in there. Mike. I think you're muted, Mike.
Thank you, Mr. Chairman. Appreciate very much the presentation and would definitely like to align myself with the comments around, the powerfulness of the material that was presented and the effectiveness of the same. In particular, would also like to echo Vicki's remarks around partnership with other state agencies. Clearly, as the Medicaid agency, we have a very strong interest in health equities work and trying to pursue in partnership with others progress and in that area. And this is one of a significant agenda item for us. So we do have some folks with a great deal of expertise in terms of the Medicaid program and strategies, measures, et cetera, around health equities, and would just like to offer our support of this effort and the opportunity to partner, as Vicki mentioned, with Access Health, with the group who has brought this work together, and with our other state agency partners. And thank you.
Mr. Chairman, very quickly, let me just one quick comment that as the Mr. Chairman indicated, Access Health has limited resources, and our resources are dedicated to a specific purpose. So whatever we do going forward, we will have to partner with other organizations with more resources to move this initiative forward. So we look forward to engaging with the other state agencies, as well as other community-based organizations, such as the Connecticut Health Foundation, the Universal Health Foundation, any organization that's focused on addressing health disparities. We are ready, willing, and able to work with them, share everything that we're doing. So the strategy that we are working on, come back to the board, will include the collaborative efforts that we will seek going forward.
Thank you, James. Any other board members with a question or comment, please?
Mr. Chair, this is Heather Aaron. May I comment?
Yes, please.
Okay. So, good morning, everyone. And I want to thank the firm and Access Health for providing this this snapshot of an ongoing problem, of a historical event in modern times. And I'd like to say that it's not news, and many of us live this every day and can give some very strong perspective and need more to be included in the communication. Discussion about bringing in all the other agencies, I think that's a wonderful idea. We have lots of expertise, and that expertise should be used to change policy, because the emotional change will take some doing and a very long time. But a policy change mandates changes in how we form, how we pay for services to be provided is the economic engine that will be helpful. So I think we have to look at reality, and we have to look at the things the low-hanging fruit that we can adjust immediately. I would like to ask if in that ideation process that we involve the agencies, DSS, DPH, and others, so that we can pull some great ideas that have been formed but not yet have been executed. Again, COVID has interfered with normal processes and has heightened things that need to get done, as Vicki alluded to. This is not an insurmountable problem. This is actually something we can fix, because the basis is poverty and economics. And that is something one of the richest states in the country can certainly handle. So I just wanted to make that comment, Mr. Chairman. Thank you.
Thank you, Heather. James, would you like to add something to Heather's comment?
Again, as we are going through, I appreciate the overture to us to engage to engage with the DSS, OHS, and DPH as we go through the our ideation process. But we would also maybe include some other nonprofit organizations who have similar focus. So again, we'll reach out to all the organizations as we move forward.
Thank you.
Question?
This is Yvonne Ado. Mr. Chair, I just want to echo everything that everyone has said, and just want to add that for me, the striking part in this whole conversation is the implicit bias that also persists in the delivery of care itself. And I think it also exists in behavioral health care as well. So I will just ask that Mr. Mitchell include DMAS as well in the ideation process. Thank you very much.
Will do. Thank you.
Thank you, Yvonne. Any other questions or comments? Okay, again, very compelling. I liked Steve's word, stunning. I think anybody who watches this or is subject to the presentation would think that's I think a fair word. With that, I'm going to turn this back over to James for future agenda items.
Mr. Chair, thank you very much. Just very quickly, just a quick summary of where we're going. In the next couple of months, we're going to come back to the board with the as we prepare for 2022 health plans, and also any work we do going forward to help address any challenges, some of the issues that were elevated today during our discussion. So we would have to establish a subsidiary because to do anything at all, as well as any other strategic initiatives that we may have to take on as a result of bills that are being considered at this within the state legislature. So more to come on that. So those are the three biggest issues going forward. In the future months and past after the summer, we will come back. Our budget will be coming forward as well. Our budget for the next fiscal year, which starts July 1, will go to our finance committee in the April-May area timeline and come back and go to the board for approval. As I think I've indicated in last month or the month before last, we had some challenges. Revenue streams are projecting to be lower in out years because of issues beyond our control. So we have to manage for this as well, and our budget will reflect that. But more to come on that.
Thank you, James.
Thank you.
Mr. Chair?
Yes.
I'm really sorry. I'm sorry, James. I tried to get in before the item switch, but I missed it, and I apologize, Mr. Chair. But I just wanted to follow up with a comment, and a very important comment that Heather Aaron made, that Deputy Commissioner Heather Aaron made, and I want to second. And I think it's important that we talk about it as we move forward, and that is how we pay for healthcare. In order to address a lot of the issues that have been highlighted here today, we really have to think about the way we're currently paying for healthcare. The way we currently pay for healthcare really disincentivizes addressing issues that patients present with, and particularly Black, Indigenous people of color in the state of Connecticut and across the country. We don't traditionally pay for team-based care, community health workers who can address issues that people face in communities and can help be a bridge between a patient and an MD or an NP and a PRN. We don't address nutrition in the practices generally, pharmaceutical issues, never mind risk assessments that people come in the door with. People are much more than patients when they walk in the door, and health is much more than health care. And we're going to have to grapple with that going forward. And I bring it up today because it's relevant for purposes of plan design and what we expect or what we hope plans offer. Now, we do a lot of work with health plans around designing different payment mechanisms, whether it's value-based insurance design or different payment models. But the future of healthcare in terms of the way it's paid for and delivered has to change to really address some of the outcome pieces of what you saw here today. And I just wanted to throw that point in because I thought it was a really critical point that that Commissioner Aaron made. And I apologize for inserting it so late.
No, not at all, Vicki. That's all right. Okay, anything for the good of the order? Okay, if not, the chair will entertain a motion to adjourn.
So moved. This is Vicki.
Thank you. Second?
Second by Ted.
Can we have a roll call, please?
Sure. Paul Philpott,
Yes.
Gregory Messner,
Yes.
Mikey Goldberg,
Yes.
Brian Ritter. Brian Ritter. Steve Hernandez,
Yes.
Peter Doolittle,
Aye.
CC Wood,
Yes.
Thomas McNeil,
Yes.
Victoria Veltri,
I vote aye. Thank you.
and Matthew Brockman.
Yes.
Okay, the ayes have it. The meeting is adjourned. Thank you very much.
Thank you so much.
Thank you all.